Hello and welcome to the video. Today I'm going to be talking about understanding antibiotics in terms of the pathophysiology and the clinical application. So let's start right at the beginning. Bacteria can be broadly classified into either gram-positive or gram-negative bacteria based on their appearance on the gram stain. Gram-positive bacteria appear purple on the gram stain and are characterized by having this thick peptidoglycan layer, which makes up the cell wall. In contrast, gram-negative bacteria appear pink on gram stain and do not have a thick peptidoglycan layer, instead having an outer membrane as shown here. These structural differences explain why some antibiotics work for gram-positive bacteria and not gram-negative bacteria, and vice versa. Antibiotics are either naturally occurring or synthetic molecules which have the ability to impair the growth or kill bacteria. They do so by targeting one of three important cellular processes in bacteria. Number one being cell wall synthesis, number two being protein synthesis, and number three being nucleic acid synthesis. The two main antibiotics which affect cell wall synthesis are the large class of beta-lactam antibiotics as well as the glycopeptides, namely vancomycin. Beta-lactams work by inhibiting penicillin binding proteins, which are important for cell wall synthesis, and thus beta-lactams inhibit cell wall synthesis, leading to killing of the bacteria. Similarly, glycopeptides such as vancomycin bind to the terminal growing peptide chain during cell wall synthesis and thus inhibits the synthesis of the cell wall. In terms of inhibiting protein synthesis, a number of classes of antibiotics block ribosomal function. There are two main bacterial ribosomes, the 50S and the 30S ribosomes. The macrolide antibiotics, as well as clindamycin, inhibit the function of the 50S ribosome, while aminoglycosides and tetracycline antibiotics inhibit the function of the 30S ribosome. Either way, inhibition of ribosomal function leads to decreased protein synthesis, and with the inability to produce essential proteins, bacteria are not able to survive. And lastly, we have nucleic acid synthesis, where there are a number of different classes of antibiotics which affect different components of this. For example, the fluoroquinolones, which inhibit DNA gyrase and thus impair DNA synthesis, trimethoprim and sulfamethoxazole, which affect folate synthesis, and metronidazole and nitrofurantoin, which are thought to create free radicals which cause internal damage to nucleic acids within the bacteria. We'll next discuss the beta-lactam group of antibiotics and then proceed to discuss which antibiotics to use in specific clinical situations. The beta-lactam antibiotics are probably the most commonly used antibiotics and consist of three main classes: the penicillins, the cephalosporins, and the carbapenems. These antibiotics share the common feature of having a beta-lactam ring and differ in their side chain structure. These differences in side chain structures give rise to differing affinities for different penicillin binding proteins, which explains why some beta-lactams, particularly the carbapenems, are very broad spectrum, whereas other beta-lactams, such as the early generation cephalosporins, have a much narrower spectrum. Within each of these classes, there are several specific antibiotics, each with their own different antibacterial coverage. Since the discovery of penicillins in the late 1920s, penicillins have been in widespread use, and it is quite uncommon to find bacteria that are still sensitive to penicillin alone. These days, the only bacterial infection that is still quite sensitive to penicillins is that of syphilis. There are variants of penicillin, namely phenoxymethylpenicillin or penicillin V, which is an oral tablet which is particularly useful for treating ear, nose, and throat infections, specifically streptococcal infections. Benzalpenicillin also has similar coverage and is also useful for streptococcal infections and comes in an intramuscular or intravenous formulation. This is often used to treat moderate severity community-acquired pneumonia. Next, there is amoxicillin and ampicillin, which is similar to benzyl penicillin in that it comes in an oral amoxicillin or intravenous ampicillin form, but is broader spectrum, namely having more gram-negative cover, and is therefore more useful in intra-abdominal and urinary infections. Next along the list is another synthetic penicillin known as flucloxacillin, which is specifically designed to cover Staphylococcus aureus. Because this is a common pathogen for cellulitis or skin and soft tissue infections, flucloxacillin becomes very useful for treating Staph aureus infections. It also comes in an intravenous and in oral form. These days, there are high levels of amoxicillin resistance, namely through bacteria producing what are known as beta-lactamases, which are able to inactivate the penicillin beta-lactam, thus preventing its ability to inhibit cell wall synthesis by inhibiting the penicillin binding protein. We have gotten around this by developing what are known as beta-lactamase inhibitors, one of which is known as clavulanic acid, which comes in combination with amoxicillin. Thus, this inhibits the beta-lactamases that are potentially being produced by the bacteria and allows amoxicillin to carry out its function as a cell wall synthesis inhibitor. In doing so, amoxicillin with clavulanic acid together has a much broader coverage of gram-negative and anaerobic bacteria compared to amoxicillin alone. And lastly, of the penicillins, we have piperacillin tazobactam, which is similarly a penicillin and beta-lactamase inhibitor combination and has very broad coverage in terms of covering most gram-positives, gram-negatives, anaerobes, and Pseudomonas. The cephalosporins are another class of antibiotics which, like the penicillins, go through a similar progression of generations where they generally go from gram-positive to increasing gram-negative coverage. Starting with the first generation cephalosporins, there are the oral form of cefalexin and the intravenous form of cefazolin. These are particularly good at covering gram-positive bacteria, particularly Streptococcus, and to a lesser extent Staphylococcus as well, but also have some gram-negative coverage, such as Escherichia or E. coli, making them useful, particularly cefalexin, for urinary tract infections, as well as skin and soft tissue infections, which is what cefalexin and cefazolin are usually used for. The second generation cephalosporins are not at all commonly used, and hence are not being discussed here. The third generation cephalosporins, namely ceftriaxone, is a commonly used antibiotic because it has broad gram-negative coverage while also having good gram-positive coverage, particularly for Streptococcus and to a lesser extent Staphylococcus. The gram-negative coverage of ceftriaxone is much broader than that of cefalexin and cefazolin, and hence it is useful for intra-abdominal infections, urinary infections, as well as chest infections, given it covers Streptococcus extremely well, while providing coverage to things like Moraxella, which amoxicillin does not. Ceftazidime is considered a halfway between third and fourth generation cephalosporin, where it has similar coverage to ceftriaxone but differs in that it specifically covers Pseudomonas, where ceftriaxone does not. Cefepime is a further improvement on this, considered a fourth generation cephalosporin, where it has broad coverage, not unlike piperacillin tazobactam, including Pseudomonas coverage, but doesn't have as good anaerobic coverage. Ceftaroline is a fifth generation cephalosporin, which is a further improvement on cefepime in that it covers MRSA, or methicillin-resistant Staphylococcus aureus. This is a very broad-spectrum antibiotic and is rarely used, at least in Australia where I work. And thirdly, we have the carbapenems, which, generally speaking, have the broadest spectrum of the beta-lactam antibiotics, including excellent gram-negative cover, some anaerobic cover, some gram-positive cover, and Pseudomonas cover, particularly for imipenem, meropenem, and tebipenem. Ertapenem has limited Pseudomonas coverage, but its use is that it has the longest half-life and can be used through hospital-in-the-home systems, where once-daily dosing of ertapenem is adequate. Apart from Pseudomonas, carbapenems are also used to treat extended-spectrum beta-lactamase, gram-negative infections, as well as infections from the escapum organisms, which I'll discuss a bit later. Because of its very broad spectrum of activity, it is generally reserved for these few indications, as part of antimicrobial stewardship. So in summary, the beta-lactams are a large group of antibiotics which includes the penicillins, the cephalosporins, and the carbapenems, of which there are several specific antibiotics within each of these classes, which all have slightly different coverage. In general, the first or earlier generation antibiotics tend to have more gram-positive coverage, and they have broader and increasing gram-negative coverage in further generations. We select which antibiotic to use based on the suspected infection and try and avoid broad-spectrum antibiotics if possible, as part of antimicrobial stewardship, and to avoid the unnecessary use of antibiotics which can promote the formation of multi-resistant organisms. At this point, I might briefly talk about penicillin allergies, which is something that is commonly encountered in clinical practice. The most important thing to do is to ascertain whether this is a true penicillin allergy or not. If there are signs that this is a true penicillin allergy with a severe reaction like anaphylaxis, in general, you should try and avoid that specific penicillin and probably cephalosporins as well. If the reaction is a non-anaphylactic reaction, such as a rash, and they had that reaction to a specific penicillin, then cephalosporins are probably safe in this scenario, whereas it would be very risky to give cephalosporins if the reaction was an anaphylactic reaction. However, having an understanding of the beta-lactam side chains can help you further understand the likelihood of cross-reactivity in penicillin allergies. For example, if a patient has a non-anaphylactic reaction to amoxicillin, one may think that it would be safe to give cefalexin. However, amoxicillin and cefalexin both actually share the same beta-lactam side chain, and so if someone has a true allergic reaction to amoxicillin, they're likely to possibly also have an allergic reaction to cefalexin, and hence the rule of being able to give cephalosporins when they have a non-anaphylactic reaction does not hold true in this particular situation. Similarly, a patient who has an allergic reaction to amoxicillin is unlikely to have a similar allergic reaction to ceftriaxone because they have completely different beta-lactam side chains. Tables exist which outline the side chains that are involved in all the different beta-lactams, and these should be consulted when deciding which beta-lactams are likely to have allergic cross-reactivity. But in general, the more different the beta-lactam is from the other, the more likely it is not going to cross-react. So for example, ceftriaxone being a third generation does not share the same side chains as the first generation, like cefalexin and cefazolin, just as an example. So now that we have an understanding of the underlying pathophysiology behind antibiotics and have an understanding of the beta-lactam antibiotics, which are a common group of antibiotics, we can now move on to discuss which antibiotics to use in which specific clinical scenarios.